Hello, everyone, and welcome to today's ARC Talks webinar on neuropathy and amyloidosis. My name is Lori Bulpett, and I am the Manager of Healthcare and Education at the Amyloidosis Research Consortium, or ARC. Before we get started, I just wanted to point out some of the features of this platform. We have set aside time at the end of the presentation for Dr. Barrell to answer questions. So feel free to type your questions into the box provided, which should be at the bottom right-hand corner of your screen. And you can also resize or hide any of the boxes if you prefer the slide box to be a bit bigger on your screen, for example. You would simply use the buttons in that box's header to adjust. And just a little bit about ARC, if you're not familiar with us. We were founded in 2015 with the mission to accelerate the development of and access to new and innovative treatments for systemic amyloidosis and improve quality of life for patients. We work closely with patients, patient organizations, physicians, pharmaceutical companies, regulatory agencies, and researchers to drive our mission forward. And our four main areas of focus are improving the speed and accuracy of diagnosis, increasing the understanding of the science of the diseases, accelerating the approval for effective treatments, and enhancing quality of life for patients. And neuropathy and other neurological issues is a huge area of concern for patients. So we are so delighted to have Dr. Kelsey Barrell with us here today. Dr. Barrell is a neurologist at the University of Utah Health. So Dr. Barrell, thank you so much for joining us today.
Thank you so much, Lori, and thank you everybody for attending. I'm very excited to be here. I am very passionate about neuropathy, but also about this community. So without a doubt, I've found that patients and caregivers in the kind of amyloid spectrum disorders have been the most engaged of my patients. So it's without doubt that I try to come here to educate, but I get educated a lot in talking to you guys. So also looking forward to the questions at the end. A little bit about me. I'm a neurologist at the University of Utah, as Lori mentioned, and my focus is on nerve and muscle disease. So I'm a neuromuscular specialist with kind of key interest in both amyloid neuropathy as well as cancer-related neuropathy. So that's how I've kind of found myself in this really exciting area, and I'm excited to get going. So that's a little bit about me. I want to hear a little bit about you, first of all, since I can't see all your smiling faces. I want to hear from you. So I'm curious, what type of amyloidosis are you or your loved ones affected with? And Lori, I don't know if I have to do anything to advance the slide or if the results will come up on their own.
Yeah, once you advance to the next slide, it'll show the results.
Okay. Wow. That is really interesting. This is a really fantastic mix. So a lot of times I've seen really strongly AL, amyloidosis, and then less hereditary and wild type, but there's a much more even mix than I've ever had. Maybe because education has improved and we all are more aware thanks to ARC and other organizations. So that is exciting. Great. And then I also want to know what your most burdensome neurologic symptoms are. And there's more than these, but this was all that fit on the slide. So sorry if I missed your most burdensome symptom, but what are you most interested in hearing more about out of these
you should
options?
Be able to select more than, you should be able to select a few if there are a few that.
Oh, good.
Yeah.
Wow. I wonder how many patients answered that. That is 100%. Okay, well, you came to the right place. That is my area of expertise. Okay, thank you for letting me know a little bit more about you. So I don't have any disclosures relevant to today's topic. I am active in multiple amyloid outreach groups, including ARC, and have been involved in research through some of the pharmaceutical companies, Alnylam and Axios specifically. And so today we're going to go through neuropathy, starting with what it is, how common is it, how are the nerves affected in amyloidosis, what are the symptoms, the tools, and the treatment options. So neuropathy essentially is damage to the peripheral nerves. That's a really umbrella term. There's a lot of types of peripheral neuropathies, but in general, it affects the longest nerves first. So in general, we typically expect a stocking glove neuropathy, which means it will start in the toes, and by the time it gets to the knees, it might affect the hands. And why is that? Well, the nerves are very long, so all the energy is produced up in the cell body and has to be transported all the way down to the distal tips where we have our sensory receptors. And you can imagine the longer the road, the more chances of potholes. And so injury happens on the longest roads or the longest nerves first, which is why in most cases, neuropathy starts in the toes. Now, we'll talk about some exceptions. So if you have symptoms that started in your hands decades ago, I'll explain why that is as well. And how common is it? So it's one of the most common things I see in my neuromuscular clinic. And in the general population, it's about 8% of patients over the age of 55. Now, if you have diabetes, it's greater than 30%, up to 50% if you have type 2 diabetes. So this is a very common disorder. The prevalence in types of amyloidosis is not quite as clear, likely because we don't know how prevalent amyloidosis even is. And so AL amyloidosis is more common than the hereditary type. And we don't have a great understanding of how many people that is in the US. Wild type amyloidosis is more common than we think it is because 5-10 years ago, people didn't know to check for this. But the more data we have, we realize that actually in the elderly, so people over 85, it's very common, up to 25% of patients. And we'll talk about whether wild type neuropathy patients have neuropathy, have a lot of neuropathy burden or not. And then in hereditary TTR amyloidosis, this is a rare condition, just 0.4 per million in the USA. But neuropathy is a common a manifestation of this. And in general, we all know this to be true. It's vastly underreported. So you've probably all experienced going to a provider who's never heard of your disease. They don't know really what amyloidosis is. It's underreported because a lot of people aren't checking, and it's a tough thing to diagnose, as I'm sure everybody can attest. It can be a long pathway to diagnosis. So this is a quote that I just think nails it over the head. So this is a patient who told me, some people tell me this is rare. I just think it's rarely diagnosed. And that is so true. The more data we get, the more we realize that it's probably more common than anybody expected. And so as an example, there have been a lot of autopsy studies that have actually looked at different tissues of the body. And so we have here carpal tunnel syndrome, where we get a tissue from the wrist, rotator cuff surgeries, we get tissue from the shoulder, lumbar canal stenosis, tissues from the spinal column. And actually, you can see a huge portion of these patients, if you look at their tissue, had amyloidosis. Now, this doesn't mean these people clinically had the spectrum of amyloidosis. There's still a lot we don't know. Were they manifesting? Is this just something that's age-related or even clinically significant? But we can see that amyloid deposition is actually quite frequent. And when we break down the different types of amyloidosis, we learn that neuropathy is a big part of this symptomatic burden. So specifically in AL amyloidosis, patient-reported symptoms, found that about 50% of patients asked had numbness in the legs and the arms. It's even higher in transthyretin amyloidosis. So the THAOS Registry is the transthyretin amyloidosis outcome survey, and it's the first global multi-center longitudinal observation survey. We've gotten a huge amount of data collected since 2007, and we can see here that they break it down into a few different mutation types, but with some types of mutations, the prevalence of sensory neuropathy is as high as 80%. And then a few of you guys looked like 17% had wild type amyloidosis. And I think more and more we're going to see more patients with wild type amyloidosis. Historically, we thought of wild type amyloidosis as a cardiac disease. We just talked about cardiomyopathy. In my clinic, I've started to see more wild type patients, and I've actually been struck by how many neurologic symptoms they have. When I go to the literature to see what could I expect, what's been reported, there's very little data. And so it's interesting that in the past, these patients presented to cardiology and no one really questioned whether that neuropathy or other symptoms were due to this underlying amyloid deposition. But this is just a series of a handful of patients in my own clinic, just to give you kind of a feel for the symptoms that I've seen in this population. About 60% have neuropathy, 20% have autonomic dysfunction, and we'll talk more about what that means. A lot of them, 40%, have spinal stenosis. All of them have carpal tunnel syndrome. All of the carpal tunnel syndrome is bilateral on both sides, and often it predates their cardiac diagnosis and their cardiac symptoms by at least a decade. A lot of them, 60%, have what's called trigger finger, where if you have your wrist closed and then you try to open it, one of your fingers stays kind of triggered in as if you're pulling a trigger. And voice changes, as well as tendon rupture, usually a bicep tendon rupture, where you make a bicep muscle and you have a Popeye bicep, is also relatively common in up to 40% of patients. But the important thing always is providers might not know about all these symptoms unless they ask the right questions, right? So how and why are the nerves affected by amyloidosis? Well, we all know that amyloidosis essentially is a problem with protein misfolding. And so no matter really which type of amyloidosis you have misfolded proteins that make kind of this glue-like substance, the amyloid fibrils, which really glue up and gum up nearly any organ, right? So the actual clinical symptoms are due to amyloid deposits, and the symptoms depend on which tissues are preferentially affected. What's interesting in neuropathy is the amyloid deposits, patients always ask, what part of the nerve is affected by amyloid? And my response to them is, what part isn't? The amyloid really can glue up and gum up all parts of the nerves. And so, for instance, the amyloid can deposit along and within the nerves themselves. And this is a picture of a nerve. It's a little hard to see. The green substance is the amyloid, and that's right in the heart of the nerve, and the nerve's kind of here around the outside. It's not showing up great on this slide, but on the slide it was both inside and outside the nerve. Amyloid also will affect the vessels supplying the nerve, so the vasculature. A very common way that people get symptoms is when nearby tissues have amyloid deposition that compresses a nerve. And then there's also direct toxic effects to the amyloid particles on the nerves themselves, especially best understood in AL amyloidosis, that toxic effect. So it's found in all layers of the nerves and really all parts of the nerves. Does neuropathy vary with amyloid type? Yes and no. So you cannot distinguish the subtype of amyloid based on clinical symptoms. So I can't see a patient in clinic and say, I think this patient is TTR versus I think this patient is AL. But there's more in common than is disparate. So both of these types, TTR and AL, will present with a similar looking neuropathy. This neuropathy tends to be symmetric, so equal from left to right. It tends to affect the sensation more than the musculature, so people will experience kind of sensory changes, at least initially. And as I mentioned at the beginning, it tends to be this stocking glove pattern, which means it's length dependent. It begins in the distal tips of our legs and our toes and then works its way up. And then often it will be followed later with motor involvement, meaning weakness. So that's the typical pattern that is common between both types. There are some differences, but the huge variability in each patient, in each geographic region, makes patterning kind of tough. So in general, we find that TTR, there's a longer time to diagnosis, and so patients might have neuropathy, but won't actually receive a diagnosis for a longer period of time. And then with TTR, I've seen more severe autonomic failure and more severe weakness earlier on. AL, there's often wider organ involvement. So a lot of times my AL patients, I might be tipped off that this could be AL because in addition to the neuropathy, they have a lot of heart and kidney and sometimes even liver earlier on. In the symptoms, so a lot of patients will have difficulty explaining their symptoms and they feel like they're lost. I don't know how to describe my symptoms because they feel like they're going crazy. They feel like these are so unique. The reason being these symptoms are very strange. They can take you by surprise and they can change a lot. And the interesting thing about the symptoms and why you can have so many different symptoms, you can have both simultaneously numbness, so lack of sensation, as well as extra sensation, painful sensation. The reason you can have this variability is because there are different types of nerve fibers. And depending on which nerve fiber is injured, you have different symptoms expected. So for instance, we have the smallest nerve fibers at the top. The smallest nerve fibers don't have much insulation. So the axon is the red part where the nerve signal's carried. The yellow is the myelin. It's like a insulated sheath that helps transmit that electrical signal. And so the smallest nerves don't have much myelin. That means they're not very protected. They're easier to damage. And so we typically see small fibers affected earliest on in the course. In those small fibers, when they become dysfunctional, since they carry pain and temperature information, people describe a constellation of pain, burning, tingling, pins and needles, shocks. But I've heard itching, vibration, bee stings, gravel in the shoes. I've heard kind of all of these abnormal sensations that people will describe. And so this is very common, especially early in the course. The next size nerves are the autonomic nerves, which are thinly myelinated. They have a little bit of insulation. And when the autonomic nerves are affected, people will have autonomic symptoms. And we'll go into further detail on what those mean. But things like lightheadedness with standing, gut issues, urinary or sexual issues will all be under the autonomic symptoms. The larger sensory nerves carry touch and pressure. And so people who have a larger nerve issue, kind of maybe later on in the course, will experience numbness, imbalance, and not being able to feel kind of vibration or position of their feet in space. And last but not least are the motor nerves. And when people have motor nerve involvement, that's when they start to notice weakness and loss of muscle mass. And that usually comes later on. But it's important to know that frequently there's going to be a combination of the above. So autonomic neuropathy, what is that? So the autonomic nervous system is the nerves that control involuntary bodily functions. This is the stuff we ignore if it's working well. We only focus on it when there's something that's going wrong. And so if you've ever heard the term fight or flight, rest and digest, that's the system. So it is the system that either activates you if you need to run, gets your blood pressure, your heart rate up, or helps you when you don't need to run, when you're digesting food, dealing with toxins through the kidneys. And it really impacts the whole body. And so it can affect decreased sweating or difficulty adjusting to the dark, because it actually affects your pupils in your eyes, how large those pupils are. A very common symptom is called orthostatic hypotension, where you have lightheadedness when you stand up. And that's a matter of the vessels, the blood vessels, not being able to squeeze down to keep the blood pressure up going to your head when you're all of a sudden up against gravity. Because when you stand up quickly, gravity wants the blood to go to your feet and pool in your feet, but your body's vasculature needs to squeeze really tight to keep it up in your head. Digestive issues are common, and it's the whole spectrum: diarrhea, constipation, often alternating with both, poor appetite or feeling full too early or feeling bloated. We see those things. Urinary issues, also kind of the whole spectrum of having issues with retention or frequency or urgency or incontinence, not being able to hold your bladder. And then sexual dysfunction is also very common, often in manifesting as erectile dysfunction. Another really common symptom, I mentioned it in wild type transthyretin, but common in all forms of amyloidosis, something called carpal tunnel syndrome. So this is something you guys might have heard of or had family members who've had carpal tunnel. It's very common, and essentially it's what's called a mononeuropathy, which means a single nerve is affected. It's compression to the median nerve, which travels down through the wrist, and that median nerve gets compressed when amyloid deposits in a tight structure and pushes down on that median nerve. The classic symptoms are numbness, pain, and eventually sometimes grip weakness. These symptoms can initially be worse with action. So repetitive use of your hands, if you're typing, using power tools, knitting, crocheting, also in sleep. People sleep with their wrists bent. We don't realize it, but we do. And that compresses the nerve even further. So people waking up in the morning or in the middle of the night wanting to shake their hand out, that's a very common symptom. And it's good to identify because it's one of my favorite things to diagnose when I'm in my EMG lab where I do nerve conduction studies, because it's something that is quite treatable. And conservative management usually involves just wearing a wrist splint at night. You can do steroid injections to the wrist, but there's also very effective low-risk procedure called a carpal tunnel release that most patients, when they have them, are quite satisfied with the results. And it's effective whether you have amyloid or you don't have amyloid. There is a growing number of recognized symptoms in amyloidosis. And so, historically with transthyretin, we knew about the neuropathy that can affect the autonomic nervous system. We know about the heart failure. Carpal tunnel has been recognized, as well as vision changes, vitreous opacities where people can kind of see floaters. But over the last 10 years, we've really had this expanding phenotype with lumbar stenosis, so that's kind of back pain and symptoms from that. Something called dysphonia, where the amyloid can deposit near your voice box and change the voice quality, making it harder to project or having a more strained hoarse voice. We mentioned trigger finger and tendon rupture can affect the kidneys. And then it can also affect what's called the central nervous system, essentially the brain. This is more rare, but we do see some people who have mutations that are more likely to have brain disorders like memory loss and seizures, hearing loss, and strokes. And then AL amyloidosis, we think of affecting many organs, often at the same time. So nephropathy is kidney issues, heart failure, the neuropathy, liver and spleen dysfunction. You can have soft tissue abnormalities like an enlarged tongue, skin nodules, or purplish discoloration over the eyes, carpal tunnel syndrome, the laryngeal involvement that I mentioned before, as well as some more focal abnormalities affecting the gut or other tissues. So quality life, that's something that I think isn't highlighted enough in the literature and in people's individual practice, but I think it's highlighted at home, and it's probably the most important thing to address that just doesn't get addressed enough. So I think it goes without saying that amyloidosis has considerable impact on all aspects of life. And this is grossly underestimated by clinicians. I think it's starting to gain some traction in clinical trials where they're focusing on some symptoms that really have a huge impact on quality of life. In some of the recent treatment trials use that as one of their endpoint markers, a quality of life assessment. So I'm pleased that hopefully we're going to get better, but I hear you if you're saying, a lot of your concerns have not been adequately addressed in the past. So this table just up here on the side is just emblematic of how quality of life is affected. And so here in red is hereditary TTR. And then there's a bunch, it's comparing quality of life measures to other common diseases. The lower the number, the worse. And so you can see, in light blue, there's multiple sclerosis, which we think is being a pretty debilitating neurologic condition for some, diabetic neuropathy with amputations, and heart failure, irritable bowel. And you can see, compared to these other pretty profound disease states, actually hereditary TTR has a lower quality of life when compared to it. If you break down even just one modality, so physical functioning, what does that mean? That really is everything. And so with the disability score, 0 is great, 50, to 100 is very profoundly affected. You can see that people are impacted in all parts of their day. So day-to-day work, getting dressed, standing up. And so these are things that are so all-encompassing that don't always get addressed in the clinical situation or encounter. And because there hasn't been, I think, enough data on quality of life, I actually went to Isabel and asked her, what do you know about quality of life? Because I know ARC has been very active in trying to emphasize the importance of quality of life. And one thing she helped provide for me is a patient-focused drug development initiative in 2016 to really give the FDA and pharmaceutical companies an idea of what patients thought were key issues. And so AL, a lot of, and this is paraphrasing, so I did not get to write down everything that was mentioned. Everything was important, but in AL, there's a lot of difficulty distinguishing between symptoms of the disease versus symptoms from the treatment. So that's a big frustration, that both the disease and the treatment can really cause a lot of disturbance in life. There is the burden of amyloid on all aspects of life. So it's mental, emotional, physical, and financial. And that extends well beyond when you're diagnosed and treated. That goes, can follow you the rest of your life. Because this is so rare, there's been difficulty finding experienced providers, and then also navigating the entire medical process of insurance and all of that, and also clinical trials, finding the right clinical trial or deciding, does a clinical trial fit for me? Some of the highlighted symptoms that were most disturbing were fatigue, weight loss, neuropathy, and cognition, so memory symptoms. And then in transthyretin amyloidosis, a lot of patients found that due to the hereditary nature, the concern really extends beyond themselves in their lived situation to their family members. The concern of, are my offspring going to have a similar course to me? Do I need to talk to all my aunts and uncles and make sure they're being tested? There's a very significant financial burden. Clinical trials have been difficult to navigate. And some of the highlighted symptoms are the orthostatic hypotension, GI symptoms, incontinence, so urinary or bowel incontinence, neuropathy, fatigue, visual floaters, erectile dysfunction, and swelling. So many, many symptoms. And then both AL and TTR, there's a lot of impact on social emotional well-being. So these diagnoses can lead to anxiety, depression, isolation, even post-traumatic stress disorder. So the fear of getting a new scan, what will it show? Will my cancer be gone? Or the fear of getting your genetic results back. And one of the reasons that amyloidosis has historically been so hard to diagnose and so many years go by between symptom onset and a clear diagnosis in many cases is that it involves so many different systems. And the medical system, works in silos sometimes. And so the cardiologist might not be talking to the hematologist or the neurologist or the kidney doctor. And so they're not always asking questions that get at the multi-system nature of this disease. The way that we need to make the diagnosis is really thinking in symptom clusters. And so one thing that I like to kind of educate my trainees and my fellow colleagues is that if you have a neuropathy and you have one or more of the following, we really need to consider amyloid. And so it's important to ask questions about autonomic dysfunction. So the lightheadedness with standing, urinary, frequency and that sort of thing. It's important, even as a neurologist, to ask about heart failure and what kind is it. We expect it to be with preserved ejection fraction and or having abnormal rhythm problems. Asking about bilateral carpal tunnel syndrome and also family history of such. GI complaints, whether there's spinal stenosis, renal abnormalities, who in the family has any of these symptoms, including neuropathy, and then some of the other rare things like trigger finger, voice changes, and vitreous opacities. And if you see a cluster of these, that makes a convincing argument for a workup. So we really need to think outside of our silo to make this diagnosis. Moving on to treatment. So there's two main pillars of treatment conceptually. One is targeting or preventing the underlying disease course. So this involves things like targeting the amyloidosis cascade, treating comorbid risk factors. So if someone also has diabetes or high cholesterol or low vitamin B12, that is compounding or making worse the neuropathy. And then exercise. And then there's targeting the symptoms. So symptom management, that can include topical agents, oral prescriptions, and then alternative and complementary treatments. So AL amyloidosis is kind of unique because it's treated as a cancer with chemotherapy. And so the goal is reduction of the free light chains by targeting the plasma cells with a quick and complete response. And I'm no oncologist, so I can't go into great detail, but the backbone of treatment is chemotherapy in most cases. Historically, the standard of care has been melphalan and dexamethasone. Recently, I've seen a lot of bortezomib-based treatment. The acronym is CyBorD. So it's a combination therapy, including bortezomib. One thing that I've experienced is CyBorD is very effective for AL, but the main treatment, bortezomib, in that combination is very neurotoxic and causes a lot of painful neuropathy. So again, it's the frustration of sometimes treating the cancer causes more symptoms. And then more recently, there is daratumumab, immunologic medication that's had really, really good outcomes. And then stem cell transplant is associated with a very deep response in the right patients. TTR treatment, there's been a lot of breakthroughs, as many people have heard, over the last 5 years. So it's a really exciting time. And the treatments are impacting multiple sites along the amyloid cascade. And so initially our main option was liver transplant. But there are 2 new genetic treatments that some people might have heard of. One's called patisiran or Onpattro. The other is inotersen or Tegsedi. And these are the new kids on the block that basically silence or knock down the mutant TTR from being produced in the liver, knock down the levels of that mutant TTR by about 85 and up %. And then there are treatments that stabilize the amyloid in a non-toxic form. This is called a tetramer. So when it's a tetramer, it's stable and therefore will not form the amyloid deposits, which the organ dysfunction comes from the amyloid deposits. And then they're investigating, so there's a lot of research underway on once you have amyloid deposition, can you degrade that deposition? Because even if we knock down the production and keep things stable, if you've already had a lot of deposition in your organs, you're going to have symptoms from that organ deposition. So is there a way we can turn back the clock further and take away the damage that's been done? So I mentioned exercise. That might have surprised a few people as far as something that actually can target the underlying disease. And what is the evidence? So this is not a loose statement that exercise does the body good. There's actually very objective data that I find quite exciting. And essentially what this study was done in pre-diabetic neuropathy, but it's been reproduced in many forms of neuropathy, including chemotherapy-induced neuropathy. This study took a biopsy of patient's skin and counted the nerve fibers going through the skin. And so normal is a lot of black staining nerves here. And then this patient with a neuropathy, you can see there aren't as many nerve fibers. And you can actually objectively count the nerve fibers in your skin. And so this study would divide the groups into standard counseling, which is your doctor saying you should exercise more and eat better, versus a more aggressive approach, which was the exercise group, where there was a coach meeting with a patient every week and a nutritionist meeting twice a month, going through a rigorous cardiovascular exercise program that was graded. So people increased their exercise capacity through a year and averaged 5 days of exercise a week, 30 minutes each day. And then at 12 months, they looked at the nerve fiber density again. And this was a very exciting result. So 0 would be no change, right? And so we would expect, as a neuropathy progresses over a year, you lose nerve fiber density. So as time goes by, you would lose nerve fiber density and it would become lower. What they found actually is, and these are just 2 different biopsy sites. So you can just look at the ankle site, which is more sensitive. In the exercise group, they actually gained nerve density after a year. So they actually had regeneration, so regrowth of nerves from exercise, versus standard of care, they lost nerve fiber density, as would be expected. So there's something about exercise that increases the body's ability to regenerate nerves. We don't understand much about why this is the case, but it's one of the only things we know of that is natural that has this effect. There are a bunch of topical treatments. This is really good when your symptoms are focal. So, just burning on the feet or in the hands. If the symptoms are really, entire legs or many sites, it might not be practical. But there's all sorts of things like lidocaine, which is, the active ingredient in the dentist injections. Capsaicin is the active ingredient in chili, so it kind of deadens the nerves temporarily. There's compounded creams, which I use a lot, which is basically a combination of different agents that get mixed up in one. And then CBD has become a very popular treatment, and the legality varies by state, and the legality varies based on how much THC, that's the more centrally acting substance, is in the compound. And so pure CBD is essentially a hemp product and is available anywhere legally. But if there's THC, a certain percentage of THC in the CBD, then only certain states allow that. And there has been some growing data to show that different preparations of this are very successful in reducing different types of pain. In my patients, just clinically, I live in a very conservative state here in Utah, and even still, there's been a lot of interest in CBD, and a lot of my patients have found that CBD topicals or tinctures under the tongue are as effective as any of the other topical treatments. The downside is there's no prescription yet for these, so they're relatively expensive, but very minimal side effects. So those are one option class. And then one of the mainstays of treatment are the oral prescriptions. What you want to know about these is all of these different agents are standard therapy, so they work pretty well. They're equally effective. And so I pick which one to use based on side effect profile and cost. So often I start with the cheaper options, and then if those aren't tolerated, then I'll move to the not so cheap options. And so gabapentin or Neurontin, the good is it's been around forever, it works, and it's cheap. So about $12 to $24 a month. But some people describe mild sedation like a head fog. It can cause swelling in the legs. Doesn't mean everybody gets that, but those would be the reasons that I would think about moving on to a different agent. Another very old effective agent is called amitriptyline or nortriptyline, similar price range, so it's very cheap. Both of these agents I prescribe at night because they help with insomnia as well as depression. The side effect profile, they kind of dry things out, so they can kind of dry up the mouth, excuse me. They can give people a little bit more constipation, and they can be sedating. The sedation is usually okay because it's a nighttime medication. Pregabalin is the newer generation of gabapentin. It's also called Lyrica, and it has less sedation, so less of that head fog, but it is more expensive than gabapentin. And then duloxetine is also a newer agent. It has less sedation than really any of these, and one of the nice benefits is it's actually at a treatment dose for nerve pain. It's a very effective antidepressant, and it works on other types of chronic pain. So it works on muscular pain like fibromyalgia, back pain, and it's just a once-a-day medication. So it's kind of a twofer if people have other pain or depression. It's a really nice agent. It is more expensive though. And then I generally do not use the narcotic class of medications. They're second or third line therapy, so they're just not as effective for nerve pain. And their side effect profile is more challenging. There's more side effects as well, not to mention the addiction profile. Complementary and alternative therapies, there's a lot of them, anywhere from supplements to meditation, physical therapy to electrotherapy, which is like stimulation, massage and acupuncture. And a lot of my patients and other people's patients have been seeking help with complementary and alternative therapy. I think because our treatment options don't always cut it. We don't always get 100% relief from the prescriptions, or there could be side effects. And so it's a very popular class of medications. As far as the literature really lacks good quality treatment trials. And so we don't have great data to show how effective it is or it isn't. But the way I think about it is usually these options do not have side effects as long as they're affordable. So as long as people aren't, going bankrupt for these fancy supplements or new electrostimulation therapy. As long as there's no harm, if patients want to try it and it helps them, that's fantastic. And so, you know, depending on the patient, a lot of patients feel support in different modalities, and it's hard to predict what patient will respond to what, but I see no harm in trying. Treatments for autonomic neuropathy are pretty specific. And so for orthostatic hypotension, lightheadedness with standing, often things that can help are pretty non-invasive. So I usually start with compression stockings. They should be hard to get on, and the higher they go, the better. So thigh highs work a lot better. They're medical grade when they have millimeters of mercury. And they just keep the fluid from pooling from your feet, which makes that your vessels able to get blood up to your head quicker. Similarly, abdominal binders keep the fluid from pooling in your abdomen. Maintaining hydration is really important. So regular hydration and getting enough salt. So salt actually keeps the fluid in your vessels. But always talk to your cardiologist. So if you have heart failure, you might have fluid restrictions and salt restrictions. Raising the head of your bed by 10 degrees about, so not adding pillows to your bed, but actually raising the entire bed. A cheap way to do that is cinder blocks under the headboards. That prevents you from urinating as much at night and in the morning, and it gets your vessels kind of used to gravity so that when you stand up at night or in the morning, you don't feel as lightheaded. And then there are some medications that keep that blood pressure from dropping. Two of the most common ones that I've seen is midodrine and Florinef. And so if these top options don't work, a lot of times I will try one of these options, these pharmaceutical options. And then gastroparesis, so that is kind of the slow gut motility. Usually we try dietary modifications, so taking small regular meals, low fat and low insoluble fiber. Liquid nutrition tends to really help if people are really constipated or have a slow gut, and actually avoiding carbonated beverages and avoiding smoking and alcohol, and then staying really hydrated and active. If these things don't work, then there are medications that get your peristalsis, your muscles moving more. It's called prokinetic medications. Usually at that point, I will send someone to gastroenterology to give them more options such as Reglan and other prescriptions. And then urinary frequency is very common. There's a lot of medications that primary care physicians feel pretty comfortable prescribing. Erectile dysfunction, also very common. It's always hard to say, is this from the amyloidosis or is this from just aging, you know, an enlarged prostate and or just aging. So there are multiple medical options, and if the medical options, the medications don't help, I have a urologist I send people to for other options like procedural options. And it looks like we still have enough time for questions. I want to thank you so much for your attention, and please email us if you have any questions, and I'd be happy to answer anything in person or through the chat at this time.
Great. Thank you so much, Dr. Barrell. That was super informative. I definitely learned a lot. And there aren't too many questions, so I think you did a fantastic job explaining everything. But we do have some good things to go through here. So I think the best way to do it is I'm able to display the questions that came in, and then we can discuss the answers to them. Great. Okay.
Oh, wonderful. Okay.
All right. So I have a question here. Can you recommend a certain diet? And I'm not sure if this question was geared towards GI distress and any symptoms in the digestive process or what. But if you could touch a little bit on any diet recommendations that you may have.
Yeah. So is there any way for the people who ask questions, are they also able to speak?
No, unfortunately.
Okay. Okay, so yeah, I guess I'll try to touch on a few points because I'm not sure if they mean for like gastroparesis, like slow gut constipation type bloating symptoms, or for neuropathy. So I'll start with neuropathy because that's kind of more of my shtick. And I get asked that a lot. So in general, there's no magic diet, but diet is important, an important consideration for nerve health. And so there are certain things that are harder on the nerves than others. And one of those are actually sugar and carbohydrates. So carbohydrates, the white things that we eat, bread, pastas, rice, kind of the mainstay of American diet, kind of, those are more likely to cause what's called reactive oxygen species in the body. Those are the things that antioxidants fight. So you hear about the importance of antioxidants for nerve health and other health. And so there is something about carbohydrates in people who have risk for diabetes that do take a toll on the nerves. And that is the same whether you have amyloid or not. It is good to try to avoid diabetes or prediabetes, try to avoid high cholesterol and high triglycerides, and then also obesity. So being overweight, having extra kind of what's called adipose or fat, all of those factors can be hard on the nerves. And so the best diet is one that kind of helps you with those risks. So something that isn't overly carb intense. And so the way I think of carbohydrates, we all need them, but there's complex carbohydrates and simple carbohydrates. Simple carbohydrates break down really quickly into fat and are really reactive to the nerves. Complex carbohydrates are more things like barley or yams or, more of those whole grains. Those are better for you in general. And so when I talk to patients, I say, eat a well-rounded diet. I don't have any, specific dietary things. The American Heart Association actually found that the Mediterranean diet is the best one for you for longevity. And what is the Mediterranean diet? It's just a nice, moderate diet that has lighter meats, so not a ton of red meats, more complex carbs. So they have a lot of legumes and beans, and a lot of produce, and not as much milk and simple carbohydrates like pastas. So I say, eat a normal balanced diet. Try to have more complex carbs than just a ton of simple carbs in your day. Keep an eye out for diabetes and treating cholesterol and diabetes if that comes into play. So that's my nutritional spiel. As far as for gut, if the issue is more kind of constipation or feeling bloated, all those things I mentioned of just having smaller meals, avoiding carbonated beverages, having more kind of easy to digest fibers is all very helpful.
Yeah, that's great. Thank you. All right, then there's a couple questions about, so this one viewer has hearing loss and ringing in his ear, and then someone else is asking for recommendations for floaters. So if you could touch a little bit on eye and ear manifestations and what that might mean for them.
Yeah, great. Those are some overlooked areas. With the hearing loss, they have looked at amyloid patients, both kind of the TTR, I think mostly focusing on the TTR, and have found that TTR patients are more likely to have kind of earlier or more significant hearing loss than just age-matched controls. So hearing loss goes up as we get older, right? Everybody eventually gets it. But it looks a little bit different. If you get hearing tests, it can look a little more severe. It's mixed frequency, so typical aging hearing loss. People have difficulty with high voices, like my voice. My patients have trouble because I have a very light but high voice, versus low frequency deep voices are easier to hear. But with TTR, it's more mixed. So people have trouble with both high and low voices. So hearing loss, we do know that is more associated with amyloidosis. I think the data is best in TTR, and I don't know the data as well for AL. Ringing in the ears, I don't know that that necessarily is TTR, which is not to say it's not. There's just not much data on it. And the tricky thing is a lot of things cause ringing in the ears and hearing loss. So there are some conditions that can cause both. And so I recommend seeing like an ear, nose, and throat doctor, and they can look into those symptoms more. But hearing loss is important, and its rate increases with amyloidosis. As far as floaters, that could represent what's called vitreous opacities, kind of things floating in the liquid of our eyeball. And that can be diagnosed and kind of managed by ophthalmology. And so one thing I recommend for all my amyloid patients, no matter what type of amyloid, is to establish themselves with ophthalmology and have a visual check, certainly if they have visual symptoms. Sometimes even before people have visual symptoms, I'll refer them to look for those vitreous opacities because that can help with the diagnosis if we don't know if someone has it or not, which is actually a common thing. It's common to suspect amyloid but not be able to diagnose it initially. You just need to see more evidence of the amyloid and get more data.
Thank you. That's very helpful. Back on the alternative treatments, this viewer is asking about infrared therapy for symptom relief. I don't believe that was something you touched on, but are you familiar with it, and do you ever recommend it?
So there are a lot of similar, there's ultrasound therapy, infrared therapy, laser, different types of laser therapy, hydrotherapy, which is water, electrotherapy, which is electrical stimulations. None of these modalities have been shown in a large scientific trial to unequivocally be effective. One of the problems is there's a lot of small trials looking at them that look really good. You know, their results look good, but not all of them have been blinded, meaning the placebo effect of a patient believing and knowing what they get is so big that it's hard to not account for that. Because a lot of these therapies, you kind of can see and know as a patient whether you're getting the intervention or not. It's not like a pill that's hard to, easy to kind of blind. So there's not strong data to show that it is effective. And so what I usually tell is some patients have found benefit in these different modalities, and I haven't had one specifically telling me about infrared, but if it helps an individual, I am all for that as long as it doesn't harm either themselves. And most complementary medications or treatments would not be harmful physically. These are non-invasive therapies. And I would want to make sure it doesn't harm the pocketbook too much either, because if there's no research supporting it, and you don't want people to pay out of pocket for something that, gives them hope, maybe would, put them in a difficult financial situation. So I think within reason, it's good to try things. I'm open-minded. If my patients say it really helped them, I will look into it, but there's not good data on it yet.
Mm-hmm. Yeah, that makes sense. Thank you. The next question here is someone put their name in the question, so I'm not going to display it. But it is a question I hear a lot of, but cramping that worsens at night, what can people do to help that?
Yeah, that's a great question. So muscle cramps, a lot of things can cause that. So it can happen in kind of the normal population, especially as you get older, but increases in neuropathy. So my neuropathy patients are more likely to have it than non-neuropathy patients. And it can be really debilitating. It can be so painful to have a Charlie horse. I'm pregnant right now, so I'm starting to get the Charlie horses, and they are awful. So things that help, kind of maybe unexpected. So I'm gonna sound like a grandma here, but there are a lot of things you can do at home. So hot baths and stretching before bedtime can really help. Massage can help. making sure you're hydrated and have enough electrolytes. So sometimes people have more cramping when they're dehydrated, and especially when they're low on electrolytes. So that's potassium, magnesium specifically. And so they have some electrolyte mixes, and I've heard they even have sprays and medications over the counter that give you electrolytes that are specifically for cramping. So those are all kind of easy things you can do. Actually, tonic water with quinine. If nothing works and they're really disabling, quinine, which used to be an active ingredient in a malaria medication, still is, used to be everybody's favorite treatment for muscle cramps. We can't get it in the US for muscle cramps anymore because it had some heart effects, so there's a black box warning. You have to go to Canada to get it. But good quality tonic water actually has a little bit of quinine. You have to read the ingredients because a lot of the new ones don't. And having, a cup of tonic water with quinine can actually help. And then, this sounds crazy, this is when I'm going to sound like a grandma, pickle juice. I don't know why, but it actually, there's data to support it. It's not just, empiric. Some patients think it helps. That's something actually in my textbooks for muscle cramping. So pickle juice can help. And then if all else fails, there are medications that can help. So one that I prescribe for nerve pain called gabapentin also helps with muscle cramping. So if people have a lot of nocturnal muscle cramping, I'll give them a larger dose of gabapentin at night. So they have a larger kind of slug of that medication, and that can really help.
Interesting. About the pickle juice. And would that just be like a couple ounces or?
Yeah, like a shot glass. Don't worry, I'm not asking you to have 8 ounces.
All right, and I think we have time for a few more questions. This one is regarding neuropathy that developed after starting a certain treatment. So is that going to be permanent or temporary? And when this individual switches therapy, can they expect the symptoms to improve?
Great question. So thank you for that question. Yes, so I'm not sure. I'm assuming that treatment is a chemotherapy.
Sorry,
or something.
Velcade injections.
What's that?
Velcade.
Perfect. Okay. Yep. So yes. So in general, chemotherapy-induced peripheral neuropathy. It's a common thing to occur, unfortunately. In general, people can get neuropathy while they're on the chemotherapy, and it's very well known with Velcade, well described. When you stop the chemotherapy, the neuropathy should not continue to get worse. So the chemotherapy can be toxic to the nerves. It can temporarily injure the nerves, but it should not continue to injure the nerves past like 2 months after you stop. 2/3 of patients with chemotherapy-induced peripheral neuropathy will have resolution of their symptoms, meaning a year out they will no longer have a neuropathy, which leaves 1/3 of patients, and that's most of the patients I see are the ones that don't have resolution, will continue to have neuropathy, but that should not get worse. And often, even though they have neuropathy, that will continue to improve over the years. And so I guess long story short is the chances are it will get better, high chances, but it will definitely should not get worse. If it gets worse, that means something else is going on. There's B12 deficiency, there's diabetes, some other factors affecting you.
Great, thank you. I think we have time for maybe 1 or 2 more, if you're okay with that. I know we're a little bit.
Yeah, I'm happy. If there's a bunch more and people are still on, I can answer as many as you have time for, Lori.
Okay, great. Someone actually uses the pickle juice. And it's fantastic.
Yes.
So good news. Okay, so this individual has some warm or hot sensations and uses ice packs to relieve those symptoms. And they're just concerned, is that safe for the nerves? Is that doing any kind of damage or anything like that? Or is that safe to do?
It's completely safe. Yeah. Either ice or heat would be completely safe.
Okay, great. Good news.
As long as you're not getting frostbite, like hiking up the mountain barefooted. But yeah, within reason, it's completely safe.
Okay, and then we have, have you specifically heard about a spoonful or two of mustard for muscle cramps? A friend of this individual's discovered it during pregnancy, and it worked amazing.
Interesting. I have not heard of that. I will look it up, though, because I am open to anything that works. I have heard one of my colleagues who's very smart, comes from Hopkins, a great institution. He actually has told his patients to put a bar of soap under the pillow. So there's a lot of different things out there, and who knows which ones work. So I will look into that. Interesting. Mustard. I don't know. Sorry.
Yeah. Well, no, it's good to hear, the input from everyone else. Something, may work for someone else. Let's see. Let's see. Someone here has tingling around the mouth. Is that related to the amyloidosis, do you think? Do you see that commonly?
That would not be a common one for amyloidosis. The reason being those nerves are not kind of the longer nerves. And so when there's tingling around the mouth, I think of more kind of sometimes electrolyte abnormalities or calcium abnormalities or a medication side effect. That would not be like a characteristic location for amyloid neuropathy, which is not to say it can't. There's such a variation in the way people experience their nerve symptoms, but that would not be a typical presentation.
Okay. And there's a number of questions here about exercise.
Good.
There's one here about
exercise. Everybody's interest.
Exercise with a fixed heart rate. Do you have any ideas on where to look for answers to this?
So I wonder, is that because there's a pacemaker or other restriction? I don't specifically, but I bet their cardiologists might have a lot of times there's something called cardiac rehab. So cardiologists work with special rehab docs and physical therapists who do special exercise training because they know that some people with certain heart conditions, say after a bypass, a cardiac bypass, or after heart failure, exacerbation, hospitalization, that their exercise routine needs to be different. And you don't want to overdo it, but you still want to strengthen the heart and the muscles without overdoing it. So I would usually go to cardiology and ask about cardiac rehab because I don't know so much with the fixed heart rate.
Mm-hmm. Okay. And another question relating to exercise. Will exercise help if I already have muscle weakness that is progressing? I'm totally numb from toes to knees and even higher.
Yeah. So exercise will still help. And, we don't really think of, it doesn't mean necessarily that you'll notice over months like, oh, things are so much better, but you'll know that you're doing everything you can to kind of slow the progression or just increase the health of the nerves. And what exercise also does is it increases your muscle stamina, which helps even if someone has a neuropathy, and we can't kind of waken back the sensation in their toes, with exercise and balance training, that sort of thing, you can improve function. Even if the anatomy is the same, you can improve your daily quality of life by making it easier to get around, by just having stronger muscles and working on balance. Balance is also a skill. Even if you have a neuropathy, actually working on balance can improve it through that kind of muscular memory and also strategies for balance. And so what I usually tell patients is find some exercise that works for them. And the goal is 30 minutes, 5 days a week, but you don't ever start at goals. That's what you work up to. And so if you're not there yet, you start with what you can do in a day. And it's the regularity that counts. You want to get a workout, so you want to feel like you're getting cardiovascular workup out, which means a lot of times my patients say, oh, yes, I exercise, I work out in the yard, or I clean my house. But the stop and go doesn't count. It really has to be sustained, where you should not be able to sing a song. Maybe you could have a conversation breathily, but you should not be able to sing a song. You should break a sweat if you're able to break a sweat, and your cardiologist lets you. And so finding an exercise that is comfortable So for a lot of my neuropathy patients, walking does not feel great, or their balance doesn't feel secure. And so actually a recumbent bike where the feet are kind of more up, they're close to their heart level, puts less pressure on those sore, tender feet. That's really good. And swimming, pool therapy is really great. But I know with COVID, we have less, access to kind of some of the places we used to go for exercise. But in general, those are the two, the pool therapy and recumbent bike, that my patients really like.
Great, thank you. So I think we do have a few more questions, but I think we are just about out of time. And I do see a lot of questions regarding the presentation or the slides being available afterwards. And you could email, here, I'll put our email back up for you all. And feel free to email me with those requests. We will put out the recording of this webinar in about 10 to 14 days with a link to it in our January newsletter. So keep an eye out for that. And feel free to request it earlier by sending us an email at the email on your screen. And thank you, Dr. Barrell. This was amazing, super informative. And thank you, everyone, for tuning in today. And have a great weekend.
It was my pleasure. Thank you so much for everybody's time. Enjoy the weekend. Stay safe. Bye.
Thank you. Bye.